So good evening, everyone, and a very warm welcome to the first lecture in our much-awaited Public Health, Architecture and Urbanism Dialogues, which we're thrilled to be launching with Ensign Global College in Pong, Ghana. Patrick Umer, Ensign Special Projects and Partnership Development Manager, is here, so I'm very pleased to welcome him and his colleagues from Ensign. I'm going to introduce our speaker, Professor Nisha Botchwey, in a moment, but first I'd like to take a few seconds of your time to explain why we thought that the bringing together of two disciplines, public health and architecture, was so meaningful, particularly at this moment in time. In 2020, at the beginning of 2020, I was living in New York, and like most people, I imagine, the pandemic initially seemed as though it was something that was happening elsewhere. Wuhan, Italy, a death in the Philippines, somewhere else. It arrived in the US with frightening speed, and it's a little hard even now to remember what those first few weeks and days were like. Panic, of course, but pretty soon, I'd say about 2 months in, before the death of George Floyd, it was clear that in the US, certainly, questions about racial and geographic discrimination, access to healthcare, social justice, and the balance between public health imperatives and individual rights were soon at the top of the political agenda. When the racial justice protests broke out for many of us working in architectural education, it was absolutely clear that where and how you live, under what conditions, whether you have access to clean water and to healthcare, mental and physical health could no longer be considered separate from architecture and urban planning, much less taught as though they had nothing to do with each other. Suddenly, architecture's dirty secret, that architects sit in neutral splendor above the murky waters of public health and public life, was out in the open, and most schools of architecture had no idea how to respond. When we think about health, we typically associate it with medical matters, not urban or architectural. We rarely think about issues of community health and wellness until a crisis, a hurricane, or a pandemic. But public health goes far beyond a crisis. It is an integral part of how we plan our cities, buildings, communities, and infrastructure. And in other words, it is an integral part of the societies and the environments in which we want to live. Some of our lectures are show and tell events. Famous architects or artists show us their work and invite us to think, dream, imagine what the world could be like. Others show the world as it is and invite us to think about real-world solutions in real time. The Public Health, Architecture and Urbanism Dialogues is a mixture of both. Throughout the series, we'll be looking at the terms public and health in different ways, examining historical trauma as well as pandemics, disease, and disasters. We have invited an unusual mix of speakers whose expertise really speaks to the breadth and dynamism of this field. So it is with great pleasure that I introduce tonight's speaker, Professor Nisha Botchwey, the Dean and Russell M. and Elizabeth M. Bennett Chair in Excellence in Public Affairs at the Hubert Humphrey School of Public Affairs at the University of Minnesota. That's a bit of a mouthful. She was formerly an Associate Professor and Associate Dean of Academic Programs at Georgia Tech and holds both a PhD in City and Regional Planning and a master's degree in the same from the University of Pennsylvania and a bachelor's degree from Harvard University. She is the recipient of too many awards to even begin to list, but among the many accolades are the William and June Dale Prize for Excellence in Urban and Regional Planning, a nominated Changemaker on the Obama White House Council on Women and Girls, a Health Disparities Scholar at the National Center on Minority Health Disparities, a Black History Maker of Tomorrow, and the author of literally hundreds of articles, essays, refereed papers, and 81 invited conference presentations. Her CV runs to 71 pages, and although I initially thought that she was of Ghanaian origin, even better, she's married to a Ghanaian. So it is making us even more special that she has flown almost 24 hours to be with us here today. So please welcome Professor Nisha Botchwey to the AFI. Thank you.
Medase, Dr. Loco, and everyone, it's very good to be here with you today. Thank you for that warm welcome. I was in sunny South Florida with my dad and boys upon the receipt of your invitation. And as I received the email, I read it aloud as my dad was next to me, and he answered your invitation for me. He said, yes. And I said, Poppy, what do you mean, yes, what? And he said, yes, you're going to Ghana to give this talk. The other half of my family lives here, and my other family is between Jamaica and Miami. Thinking about public health in this Ghanaian and African context, I cannot help but be excited about the strong foundation on which you are building and the legacy you are seeding for the population that will shape our future. Thank you for welcoming me to kick off the Public Health, Architecture, and Urbanism dialogues today with my talk on designing African healthy places. Architects and urban designers play a vital role in ensuring that our buildings and cities are healthy, not just in terms of their physical and environmental impact, but also in how buildings, spaces, and cities encourage interaction, social mixing, equitable access, and mental and physical well-being. Architecture can be transformative, changing the way we relate to our built surroundings as well as to ourselves and to each other. The built environment we shape deeply influences our well-being, yet too often this impact is underappreciated. For the balance of the hour, maybe a little less, I want to first build on the what I've done, as noted in the introduction, to say why I am doing this work now. I'll then provide some highlights on not just how the design of our environment impacts our health, but also what some of those impacts are, and the inequities in outcomes in low and middle income countries. Finally, I'll end with both two directions focused on community engagement and youth from my work in South Africa and across the US that are, I think, great models for the African Futures Institute to consider in shaping Africa's future, one that is sustainable, equitable, and healthy. And so let's start with this question. Why am I doing this work? The answer goes to who I am. I was born in Jamaica, immigrated to South Florida when I was very young, and matriculated to Harvard University, studying environmental science and public policy. While there, my academic studies started with a focus on marine ecosystems, and I wanted to understand how coastal development in the Montego Bay Marine Park impacted my bay, my coral reef, my fisheries, the areas where I would swim as a little girl day in and day out, at least in the summers. A few years later, I was working on my master's and PhD in planning at the University of Pennsylvania when both my parents developed type 2 diabetes. I was driven to understand how my very active parents living in a great environment could be impacted by this disease. So I shifted my ecosystem from the marine environment to urban communities, looking at the impacts on the health of the population. Then again, as an assistant professor at the University of Virginia, my research evolved with the birth of my 3 children. My desire to make a better place for them led me to not only focus on the ways in which places impact our health, but to take it a step further and to develop resources to help communities and youth advocate for healthier futures. I earned a master's of public health at the same time while also serving as an advisor to the director of the Centers for Disease Control and Prevention. So in everything I do, I believe in the power of youth and disenfranchised populations to overcome obstacles and build their capacity to create equitable, healthy, and sustainable futures for themselves and their communities. So now, after a decade of work at Georgia Tech and at Emory University, I am becoming the Dean of the Humphrey School, where we inspire, educate, and support innovative leaders to advance the common good, not just in the diverse world, but in our diverse world. And it is this world that we are here to consider with regards to healthy places. And so our next question is, how has the design of our environment impacted our health? So this image may or may not be familiar to you. Attention to health in the built environment started in the early 2000s with scholars Richard Jackson and Chris Katisky at the Centers for Disease Control and Prevention really just speculating on the health impacts of urban sprawl, on the design of suburbs and understanding ways in which the design of what is sprawl on the top impacts the health of the population. Many in the building industry, real estate industry, but also in the public health industry, public health field, called this junk science because we didn't really know. We had a feeling, but we didn't have the evidence on which to make this determination. Let me start here. So we had a feeling that people who lived in neighborhoods that looked like the ones at the top were more car dependent and less sedentary, whereas those who lived in the neighborhoods that looked like the ones on the bottom, they were more active. And you can see clearly that it's easier to walk if you're in the neighborhood from the bottom versus the neighborhood at the top. And so on the neighborhood on the north, the norm is to drive. The neighborhood on the bottom, the norm, what is normal, is to walk. And so the way we went about expanding this area, changing what is normal from the suburbs to more of a connected neighborhood, is by shining a light on what's actually happening in these communities, eradicating the bad policies, not bad designs, but bad policies that led to these types of developments. And then 3, educating everyone we could about what we found. Along the way, scholars around the world started studying this field. And we went from publishing just 90 articles on this topic between 2001 and 2005 to nearly 3,000 between 2016 and 2020. Today, the United States and most of the world are facing 3 major crises: the COVID-19 pandemic, health and racism, and climate change. All of these have health implications that can be addressed in part by the built environment. COVID-19 has had a major impact on public transit, limitations in physical space and internet access, protection of essential workers who can't work from home, especially those in service economies, including transportation, healthcare, tourism, and grocery stores. Widespread vaccination really is critical to bringing this pandemic under control. We also know that throughout history and around the world, families and tribes have learned to be cautious and fearful of those who are newly arrived, who look different, and who have different customs and cultures. In some societies, this has led to the creation of racist systems that discriminate against those not with the most power, those without power and influence. And this leads to substantial economic and health disparities. Essentially, racism has disenfranchised Black, Indigenous, and people of color from education, employment, and the ability to create wealth for oneself and an economic legacy for their families. Political decisions must actively opt for more equitable investment of these societal resources for improving the built environment, so our schools, housing, parks, healthcare facilities, transportation systems, and other built environment structures. In doing so, we can begin to compensate for the years of underinvestment and disinvestment in disadvantaged neighborhoods. Climate change, like COVID-19 and racism, has significant impacts on health of people throughout the world. Sea level rise threatens millions of coastal inhabitants who will be forced to migrate. As urban areas become unbearably hot, populations will move to cooler regions and demand new housing, transportation, and commercial infrastructure. We will see more heat waves, hurricanes, blizzards, maybe not in Ghana, floods, perhaps here, droughts, wildfires, with the attendant loss of property and lives. Improvement in the design of buildings, transportation systems, energy systems, water systems, and communities can help promote healthy density and mitigate the contribution of the built environment to climate change, as well as help adapt the physical environments to be more resilient and sustainable in relation to the inevitable adverse impacts of climate change on health and the society. So we've talked about some of these challenges. What is a healthy place? Healthy places are places in which people can grow up, live, work, play, study, pray, and age in ways that allow them to be safe and healthy, to thrive and to reach their full potential. And as you can see, creation and maintenance of healthy places really require that we pay attention to environmental sustainability, because in the long run, there can be no real healthy people without a healthy, intact planet. Healthy places can be small, like the table or chairs that the children and college student actually are sitting at and working at, or immense at the scale of the globe. The built environment, essentially, are those things that are designed, created, and maintained by human efforts. These are our buildings, our neighborhoods, our food stores, and the Tuesday market, public plazas, playgrounds, roadways, culture, and social policy. Yes, even culture and social policy. The built environment depends on supporting infrastructure systems for such necessities as energy, water, the wine that we're drinking tonight, housing and transportation. These systems are also considered as part of the built environment. And so the built environment really is culture and social policy set in concrete, both figuratively and literally. So just as the making of concrete requires immense, large inputs of materials and energy and lasts decades or centuries, the built environment shapes behavior and the future culture of those who live and work in it, because it shapes the behaviors that result. So this map is an example of why your address, or in the States, your zip code, is a stronger predictor of the health or your health outcomes than your genetic code. So your zip code or your address is a stronger predictor of your health outcomes than your genetic code. We should seek to optimize the design and construction of our built environments to bring the benefits possible to healthy sustainability and well-being for all populations, especially those who are the most marginalized. Those who are dying, in the example here from Atlanta, Georgia, where I live, you can live 71 years if you are in the neighborhood near Bankhead, or 84 years if you're in Buckhead, a 13-year span for neighborhoods that are just 10 miles apart. Design matters, and good design can lead to healthier and happier people who actually live longer lives. And so health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This definition goes beyond a narrowly biomedical view to include many dimensions of thriving, including comfort, happiness, and well-being. Two other dimensions I want to make here, distinctions I want to make here, are between healthcare and public health. Those in healthcare tend to be clinical and focused on individuals, but professionals in public health operate at the community level. We focus on populations. Public health professionals are dedicated to fulfilling society's interests and assuring conditions in which people can be healthy, conditions that range from effective healthcare systems to healthy environments. Design professionals, many or most of us in the room, are focused on the form, function, and operation of things and spaces. Does that sound accurate? I see a number of head nods. In architecture is the design profession that operates at the scale of buildings. Specializations focus on building types, commercial, residential, hospitals, or laboratories, and even green building principles, where we focus on energy efficiency and use of renewable resources. So as we think about public health and design professionals, I want you to consider what are some of the ways that the African Futures Institute and in your seat as a professional designer, architect, and others can partner with public health. And so I'm going to tell you a short story that is almost, 200 years old. So during an 1854 outbreak of cholera in London, this story also may be familiar to some of you, John Snow observed a far higher incidence or new cases of disease among people who lived near or drank from the Broad Street pump. And so the Broad Street pump is where you see this really long bar, and this bar indicates number of cases. These are people who drank from the pump or lived near the pump, and so he persuaded local authorities, so he had to partner with local authorities to actually remove the pump handle, and the epidemic in that part of the city soon abated. Essentially, John Snow reshaped the environment so people could not draw water from the Broad Street pump. He did what architects do. He did what planners do. He reshaped the environment. This is what we do as designers in the environment. We remove or place the handle. John Snow in this way was shaping the environment. In what ways can you reshape the built environment to minimize negative exposures and maximize positive exposures? What are the things that you can do in your practice? What are the things that the African Futures Institute can do, can advance the vision for, that mitigates the negative exposures and maximizes the positive exposures? So despite these early lessons from 1854 and others that followed, chronic disease, including heart disease, cancer, and stroke, have overtaken infectious diseases as leading causes of death and suffering. And this is data from the US, and you can see it's 1990, 1950, and 2019, and how the cause of death essentially is kind of some things are moving up and some things are moving down. But the majority of things that are moving up are those chronic diseases, the non-infectious diseases, the non-communicable diseases. And so most of the data that you see here is the top causes of death, diseases of the heart, malignant neoplasms, unintentional injuries, chronic lower respiratory diseases, and stroke. These are diseases and outcomes that result from design of the built environment. These are the spaces that we control. We have so much power in impacting the health and well-being of the population. And so when we think about this data, what does this look like in low and middle income countries? Let's take a quick look. And so we're going to look at the leading causes of diseases and LMICs. And so I want you to think about what should we be paying attention to as architects and designers and planners and landscape architects. So first is food. In low and middle income countries, the dual burden of undernutrition in the form of wasting and stunting And overnutrition in the form of overweight and obesity is particularly salient, with the burden falling primarily among the poorest. Over the last half century, while high-income countries have seen dramatic improvements in air quality, cities in low and middle-income countries have manifested dramatically high levels of air pollution, the result of a combination of factors including industry, burning solid fuels in households, and highly polluting motor vehicles. Nearly 5 million people around the world die from injuries every year. 5 million every year. And nearly 100 million require some type of health care due to an injury. Injuries are the leading cause of death for youth and have a higher incidence in low and middle income countries. The design of the built environment can have considerable impact on the likelihood of injury for most of these mechanisms, especially motor vehicle-related injuries, falls, fires, and drowning. Globally, most types of injuries decreased from 1990 to 2013, especially in high and middle income countries. But many of these decreases are due to changes in the built environment, changes in the design of the spaces, again, that we control. Most of the injuries increased in low-income countries due to the design of the built environment. More cars and unsafe passage for pedestrians are the cause. Although most transportation globally is by motor vehicles, such as passenger cars, buses, and trucks, more than half of the injuries and deaths occur among vulnerable roadway users, including bicyclists, pedestrians, and motorcyclists. While it may seem that water and sanitation issues were solved a century ago in highly industrial countries, in high and low-income countries, water access is not universal, clean, affordable, or governed fairly or consistently. There are significant water battles, even in the US. When I think about Florida and Georgia, we are fighting over water access in the United States. About 75% of households in low-income countries either do not have access to hand-washing facilities or have the facility but lack access to water and soap. Additional anthropogenic pressures expose water to pollutants from point and non-point sources. Point source pollutants involve the discharge of contaminants from easily identifiable and confined spaces, such as effluent discharge from factories and hospitals, oil refineries, concentrated animal feeding operations, sewage and municipal sewage treatment plants, but even roadways. Non-point source pollutants result from the runaway of infiltration of contaminants from diffuse sources, such as agriculture, residential, and commercial industrial land. And so the impacts of climate change on water are already being felt within communities, from drought conditions to flooding. Climate change pressures present a water paradox. Residents in some communities, especially low-income communities, low-income residents, suffer from flood events and lack access to clean drinking water. Some areas, especially in low-income countries, have informal housing settlements. We know we have some here in Accra and across the continent. This is where ownership of both land and the structure of poorly documented and where basic services such as water, power, and sanitation are lacking, which has important implications for community investment and sustainability. Architectural design to improve housing and reduce communicable disease, such as installation of window screens for malaria, better sanitation, and improved food storage, are underway in several low and middle income countries. And the World Health Organization is beginning to implement its housing and health guidelines through support with member states. Additionally, the most severe and immediate impacts of climate change, including health, including health impacts, are concentrated in low and middle income countries, especially among people living in informal settlements. With global reports reinforcing the valuable impacts of education on health, employment, poverty reduction, resilience, equity, and greater individual freedoms, there remains a gap between schooling and learning, with the greatest burden faced by low-income countries and communities. Studies in the United States continue to reveal persistent deficiencies in school facilities. These are studies about education in the United States, in addition to those in low and middle income countries. In low-income countries, the situation is even worse, with shortages of basic infrastructure as sanitary facilities, lighting, and even student desks. And as we engaged with the COVID-19 pandemic in March 2020, broadband services and access to internet was challenging across the board. And so we not only realized the summer melt, where students are forgetting what they learned during the 9 months of school, but they lost a year or two of what they had been taught previously across the globe, in addition to the US. I would be remiss if I did not say that sustainable development is key to the remedies in creating healthy places. Sustainable development is defined as development that meets the needs of the present without compromising the ability of future generations to meet their own needs. The UN Sustainable Development Goals were established in the notion around climate change and concerns were established in the 1987 Brundtland Commission report from the World Commission on Environment and Development. 5 years later, at the Earth Summit in Rio de Janeiro, this was hosted by the United Nations Conference on Environment and Development, there was growing global concern that threatened the very stability of the planet, and therefore the prospects of human health and well-being were essentially crystallized. These concerns are primarily based on the exploitation of energy, predominantly from fossil fuels, including coal, petroleum, and later on natural gas. And so in 2015, the UN Sustainable Development Goals, as you see here, and this followed the Millennium Development Goals, these are the international framework, or is the international framework for much of the approach realizing that human beings are at the center of concerns for sustainable development. And they are entitled, humans are entitled to a healthy and productive life in harmony with nature. And now if humans are entitled to a healthy and productive life in harmony with nature, then I would argue that our professions have the mandate to apply our skills to meeting this mandate. You can see that the highlighted goals, 3, 6, 7, 11, and 13, those are good health and well-being, clean water, and I can't see 7. You can tell I'm a little past 40. Thank you. Sustainable cities and communities and climate action are all connected to healthy places, all connected to healthy places. And there is a growing Healthy Cities movement that is evolving out of this work that if you have not had a chance to engage, I encourage you to take a look at. And so as we look again at those leading causes of death, we looked at the US, but let's look at this globally. In 2019, the top 10 causes of death accounted for 55% of the 55.4 million deaths worldwide. And you can see, and I'll just point out, that the open circle shows 2000, the closed circle shows 2019. So there are fewer deaths from heart disease in 2020 versus in 2019. And then by color, blue is non-communicable diseases, so those diseases that are not infectious, whereas communicable diseases are those infectious, parasitic, maternal, and nutritional, and then injuries are in the dark blue that you'll see in the following data. So the top causes of death in order of total number of lives lost are associated with 3 broad categories: cardiovascular disease, respiratory disease, and neonatal conditions. Causes of death are grouped as noted at the top. And so what do you notice basically from this first chart based on what's presented in the top 10 causes of death? What do you notice? Anything? Blue lines, green lines, is there any pattern? Maybe no real pattern yet, but let's take a look. So that's global. When we look at low-income countries, so we're going to look at low income, middle income, and high income. So let's look for patterns. Low-income countries, we have neonatal conditions. Again, these are communicable diseases. Communicable are infectious, parasitic, maternal, and nutritional. We have respiratory concerns, heart disease, stroke, so we have a mix of communicable and non-communicable. As we move to middle-income countries, again, we see heart disease and stroke, but we saw that here as 3 and 4. So these non-communicable diseases are rising higher as causes of death. What about upper middle income countries? When we look at these, we see a different pattern, don't we, than what we see in low income countries. And then finally, high income countries, heart disease, and so on. So what pattern do you see in this data? The non-communicable diseases are more prevalent in higher income and middle income countries than in low income countries. And these are diseases that often would be referred to as diseases of behavior, right? These are diseases of convenience and not diseases that are infectious that you might get because you are breathing the same air, you are drinking the same water. So this points to what I love to talk about. It seems like this is in every slide deck that I go through, is Maslow's hierarchy of needs. Maslow was a psychologist. And what he talks about here is that humans really need to realize the base of the pyramid before they can realize the top of the pyramid. Many of the outcomes that we saw on the previous slide can be addressed through interventions at the interface of health and the built environment, but we need to make sure that these basic needs of food, security, family, friendship, that those are met first. Those that focus on physiological needs, so air, water, food, shelter, sleep, clothing, and reproduction, then safety, so personal security, employment, resources, health, property, and then love and belonging, friendship, intimacy, family, and sense of connection. And then we can get to esteem and self-actualization. And self-actualization is where the creative activities fall. That's where beautiful art and music and architecture, that's where these things fall. But we can't think about that unless we know that we're safe and we have food in our bellies and our children are taken care of. We can't move to these higher levels of order, of needs, as individuals, as family units, or even as countries, until we meet the needs at the lower level. This is akin to my iceberg analogy, or some of you may have been exposed to the tree analogy. But here with the iceberg, the biggest and foundational part is well below the waterline, right? So the part that most people are concerned about is here at the top, because that's what they can see. But they don't see this massive part of the iceberg below. This is where we see systemic structures, the rules of society. These systemic structures are how the society operates. This is also where the social determinants of health are located. Those social determinants of health are based on where we live, where we were born, where we go to school, what kind of job we have. These things shape our behaviors. So if I'm from a certain neighborhood and I have access to good transportation, I have my own car, I can get to school or work, I can get my children to school, then I don't have to worry about getting in is the phrase trotro? I don't have to worry about catching a trotro. And I may be late, I may not be late. I may be stressed, I may not be stressed. I may not be able to have my breakfast that I could have in the car with mom in the personal car, right? And so the behaviors are different based on the structure of society. And then those lead to particular outcomes. And so in Atlanta, this is Atlanta, we have, I think it's a 7 or 8 lane highway on either side, so 16 lanes of cars, and we still have traffic. Whereas in, I believe this is Raleigh, they have a light transit, and you can get pretty seamlessly to the same set of skyscrapers that takes a long time in the city of Atlanta. You may be stuck in traffic for an hour, maybe 2, depending on who's in town, maybe 3. Or you could walk and see friends along the way and really be joyful and have a positive event and experience with friends. Or you may actually have some sort of a stress event as a result of road rage or something else. And so the system where you live, the stresses that you are exposed to or not exposed to, the light you have access to, that has an impact on what you choose to do, where you choose to go, how often you go out, whether or not you're sedentary, and thus what those events are at the top. The health outcomes we've been talking about, those are the events. But we as designers of the built environment, we control the base of this iceberg. And so what are you going to do with the power you have? There's another way of saying that the largest contributor to our health outcome is where we live, grow, learn, and play, and this is the social conditions. And so this amounts to 85% of our health. So these social conditions and behaviors, based on the World Health Organization, contribute to 85% of what determines our health. Healthcare, 10%, and yet we pay so much for it. And genetics is 5%. 5%. Knowing this, the role of architects, planners, and designers of the built environment in promoting population health is critical. We work at the base of this health impact pyramid because we address socioeconomic factors and change the context to make the individual's default decisions healthy. Let me say that again. We work at the base of this health impact pyramid because we address socioeconomic factors and change the context to make individuals' default decisions healthy. This is where we have population level impact. So as you go down the pyramid, you increase population level impact. As you go up the pyramid, that increases individual effort. So I have to, for instance, learn how to eat healthy rather than having healthy food in my backyard. I have to figure out, all the many jobs that I can get access to or clinical interventions rather than having access to good health care next door or having access to a good job that provides me with the resources I need to take care of my health. Government has a key role to play in ensuring healthy conditions, including a healthy environment. We also need to think about eliminating socioeconomic inequities that are at the base of this pyramid. This is fundamental to achieving public health, population-level health, not just individual health. And then a healthy built environment together with multi-level approaches. So we need everything along this pyramid, such as education, regulation, enforcement. And I was joking with Edwin and Aja about when I was here maybe 5 years ago, we were driving along the Caswell Road, and there were all these, the side shops, and there would be graffiti written on there, remove by, and I'd say, why are these still here? And my cousin said, well, sometimes the shop owners write it themselves, right? And so where's the enforcement? There's the sign, but where's the enforcement? So the built environment is shaped in a way that meets the plan and meets the needs of the community. And so I want to share just 2 examples of what I propose as potential paths forward based on my work in South Africa and across the US with my Youth Engagement and Action for Health project. And then I'll leave you with 3 short visions from scholars, architecture, planning scholars from across the diaspora. So the first project is from South Africa. And I'm suggesting that the approach here is that we work with communities to create a vision. What is the vision for the healthy place, the healthy community in Accra, in Ghana, in South Africa, across the continent? This work was done in the Limpopo region of South Africa, and we essentially went into the community, the Chapasha and Chivumo rural communities, and said, HIV is really high in your community. We want to provide medication and support. And the community said, that's not what we're interested in. We need water. And we walk far for water. We need water. So we created a photo voice project. We trained the water committee to take pictures, and in completing the photo voice project, we asked them to take pictures of 5 things. 1, what's okay as it relates to water? What's most important? What's number 1? What's not so good? Sorry about that. What's not so good? What is familial, right? So the wedding finger, right? What is family? What is relationship as it relates to water? And then what is weakness as your pinky finger? What is weakness? And they took a host of pictures. You can see we trained them on taking pictures with the disposable cameras, talked through what they came up with. We laid all the pictures out and came up with what they thought was most important as it related to this topic. They had an exhibit at the University of Venda, and you can see some of the images they came up with are just so incredibly powerful. And these are pictures from the Water Committee there in the villages, the rural villages in Limpopo. And so top of the list was infrastructure and storage. We need pipes or something to get water to us, and then we need a place to safely store it. 80%. Community and the relationship of water to the community. Who am I sharing with? Who am I not sharing with? That was also critical. Water as it related to money and cost and resource loss. Food as it relates to water and being able to use it to grow. Health and hygiene, and then pain. And so as you think about, we started with HIV. That's what we as researchers flew in, and said, this is what should be most important to you. And they said, infrastructure and storage. That's what's most important to us. You get us infrastructure and storage, and then we'll talk to you about HIV. And so that's what we did. We were able to build a water tank and train the community in a variety of approaches. I'm going to skip this one. And help get them the water access and infrastructure that they said they needed, that the community was most interested in. And I can tell you that the HIV engagement and HIV rates in those two communities are lower today than they were when we started this work years ago. Because we listened to the community and we had them tell us what they needed, we gave that to them in partnership with them. They helped us build it. And then they worked with us in the areas that we saw from outsiders were of most need, and they also realized benefit. And so some of the thoughts around climate change and health strategy here to think about planning healthy communities with communities. Engage populations to identify, design, implement, and monitor community concerns toward improved quality of life and thus health outcomes. Allow the communities to prepare and respond to other stressors successfully, and this helps them mitigate negative impacts of climate change and health and sustainability matters. The next project is one that I absolutely love because this connects to kids, and you know from the opening that my work started with a focus on marine ecosystems because I love to be in the Montego Bay Marine Park and swim at Doctor's Cave Beach. And then my parents developed type 2 diabetes, and so I was focused on health and well-being, and then I had kids. And my thought then and my thought now is, how do I equip my children, your children, with the skills they need to solve problems, to identify the evidence that will convince a decision maker to know how to make a pitch to get the resources they need to solve the problem that they, the kids, identified. I want that for my kids, and I want that for your kids. And so this is what this project does. So it's youth engagement and action for health. It's focused on physical activity. Who would be against getting kids to move more? No one. And so once they learn the skills, where they conduct neighborhood assessments, complete an advocacy project, and then learn about advocacy and health, they then have the skills to deal with gun violence, water, a whole host of issues, whatever it is that they are interested in. This is giving them voice and agency. So this project, and there's a website you can go to if interested, is a 10 to 14 week program. We focus on middle school kids, so 11 to 14, but it could be used with high school kids as well, maybe even college students. We targeted low-income students from minority backgrounds, primarily Latino, Native American, Pacific Islander, and Latino in the US. We conducted 1 or 2 different community assessments. These could be assessments in schools, neighborhoods, parks, and then we shared an advocacy presentation with a decision maker. And we didn't just create the advocacy presentation and then invited the decision maker. In week 2 of 14, we said, what are we interested in? And one group of students said, we want a water fountain. And this was in their Habitat for Humanity community where they have housing, low-income housing. And so, so who's in charge of making this decision? They came up with 5 or 6 different people, and we basically played a game that was coined by my kids in Hawaii. It's called Who Dat. So in the US, you would say, who is that? Or Who Dat would be the slang. And so it's like baseball cards. So you have a picture of a person, and they say, oh, that's council person so-and-so. And the last 3 votes were on this. That's the mayor. And the last 3 things he was interested in was this. And so by the time we got to week 13, which was the presentation, they knew who they were talking to, what would sway them, and how to get their water fountain. We had kids in South Florida, and I'll go to that next slide actually. We had kids in South Florida who basically said, we want, again, the water fountains that are next to the PE class area, we want them clean. And they presented to the principal of the school. And the principal not only changed the protocol for the janitors to clean the water fountains, he continued to go outside and fill his water bottle every day to make sure the water fountains were clean. This changed his behavior. And then the last example I'll give you is from my kids over here in Hawaii. In Lahui, they presented to their county council. And do I have a picture of my Hawaii kids? I don't have a picture of the Hawaii kids on here, but they presented to their county council that they wanted their park to be improved. And I don't know how many of you have seen the Moana movie. So it's that Disney movie, and they have like the crazy chicken that's always pecking in the ground. Lahui has chickens. Those chickens are all over that island. And the kids said, there are all these chicken holes in the ground. We can't run around. The park needs improvement. The rock wall that you've said you're going to improve for 3 years, there's still a police tape across it. No one can climb the rock wall. There are not park benches. After that presentation, they received $80,000 to do a park study. And if you check the news, you'll find, and I'm happy to send it to you, maybe we'll tweet it through AFI, that the park has been renovated as a result of the kids saying, this is what's important to us, and we need you adults to get on board, get it done. This is what we need so we can have a healthy future. And so here are just a few pictures of my kids from DC and Miami, Florida, Charlottesville, Virginia, and Maine. And so let me end with just a few words from colleagues and friends from across the diaspora. Some of you may recognize the faces here. Professor Blessing Mberu, and I call him Blessing. He's from Kenya, and he says that real progress in achieving an urban Africa without slums will include massive investments in infrastructure, including water, sanitation, waste management, electricity, good roads and sidewalks, parks and green space, transit service, and healthy housing. These are areas we engage as architects and designers. Tulua Oni from South Africa. She has a fantastic urban better vision, and I know she's one of your speakers, and so you'll have a treat when she comes and speaks, but she says that Africa's young population and dynamic cities are well placed to catalyze and accelerate a reimagination of the urban, to embrace adaptive systemic change, and to place health at the center of sustainable, inclusive, and urban development. We can do that. We have leaders in the field that are already doing that. And then finally, Emmanuel Frimpong Boma. He's in Buffalo, New York by way of Accra, Ghana. And he says, creative and equitable approaches to finance and to maintain water infrastructure that empowers community members are needed to meet the human right to water, the UN Sustainability Goals. These are things that our brothers and sisters are saying we can and should do. And I know the heart and the mission and the vision of the African Futures Institute is to realize these very things. It hasn't taken a year to get us to where we are today. It's taken decades and decades and decades and decades. It's not going to happen overnight. And so I want to encourage all of us to work towards the vision, work towards that finish line, but to give each other grace as you make those incremental steps and progress. You see those changes, don't give up. It's going to take just as much time, if not more, to dig ourselves out as it took to get us to where we are. But don't give up. This is the vision that we can work towards. I encourage us to do so. Much of the talk that you heard tonight comes from my forthcoming book, Making Healthy Places. It's out in May or March of 2022 through Island Press. And let me end by saying, Madase. It's been a wonderful evening speaking with you, and I look forward to your questions and the dialogue. Thank you.